I have been working on, sorry, this is going to do this flicking through for me. Been working on reducing smoking prevalence among Maori and all New Zealanders for nearly 30 years. And I worked in government as a policy analyst, overseeing national programs. I was the first Maori to work full-time on this issue. And then I went back to university. I did my PhD in smoking cessation. So I've been involved in very many studies and lots and lots of different trials of different interventions, and got to the height of academia, my academic career, became a professor of public health, and now I have my own centre funded by the Foundation for a Smoke-Free World. And I'm now focusing on reducing smoking among all Indigenous people of the world. Not all Indigenous people have very high smoking rates, and there are over 370 million or more, sorry about that, spread over 90 countries. So it's a really huge, interesting topic. And over the last couple of years, I've been looking at smoking prevalence rates for people across the world, Indigenous people. I guess to start with, it's fair to say you know the status of smoking and the effects of colonization for the First Nations people of Canada. You can pretty much extrapolate that out. It's been very, very similar for us here in New Zealand, Australia, the United States, and we all had, as a result, very high, disproportionately high smoking rates. So many of the effects of colonization have been the same, even though the tactics weren't always necessarily the same, pretty much very similar strategies. So my talk today, we know about harm reduction, the whole conference is about harm reduction, and in tobacco control, it's a very, I guess, a new approach. It's actually not that new, but now that we have all of the risk-reduced products, a wide range of risk-reduced products, and really trying to move to helping people switch to those and have a harm reduction approach adopted, and that's been a little bit controversial. The other aspect of harm reduction that I wanted to talk about today, which has been concerning me for several years, is the perverse effects of tobacco control policies on Maori, and it's similar for other colonized peoples as well. So I just want to talk about that, and it's part of harm reduction is to address the perverse and unintended negative effects that policies can have. So for Maori, we have the smoking rates have been coming down pretty slow. It's been glacially slow, really. When I first came into the work in around 1992, Māori smoking rates were sitting around 50%. So in 1993, you see there 54% of Māori was smoking. And that dropped to, we had previously had an 11% drop between 1981 and 1991. And then, over the next, over 10 years, we get a drop from 54% to 42%. Another 10 years, it drops to 33.5% as the last figures we have here. So it's about 1% on average per year. It's really, really too slow, and we need to be looking at ways to increase that. And of course, the risk-reduced products that exist now can help that to occur, but are being blocked, particularly in Australia. In New Zealand, we're very lucky. Vaping has been legalized here now, but unfortunately, Swedish snus and oral nicotine products were banned. So it's not completely, access there. Now, one of the main pillars of tobacco control has been the use of tobacco tax. And this really, so there we see the first table on the left, and this is work that I commissioned, one of the first projects that I commissioned. How much is being extracted from not just Maori, but all New Zealanders by ethnicity. Now, the first one there is to look at is the inequity of smoking prevalence rates. So Maori, 33.5%. Pacific Island people, we have the largest population of Pacific Island people in the world live in New Zealand, coming from the 7 closest Pacific nations to us. 23% smoking rates. We have quite a sizable population of Indian and Chinese and other Asian people. They have very low smoking rates, and the European New Zealanders are down to 13.5% smoking prevalence. The table 2 splits that by gender, and it's important to look at the difference by gender. In Asian countries, for example, in China, only 4% of women smoke, and similar in other Asian countries. So you can see down there the difference between Asian men and Asian women is quite large. Among Maori, the Maori women have higher smoking rates, and this is because Maori men's smoking rates have come down faster than Maori women's smoking rates. And one of the most common questions I've been asked over the decades is, why do so many Maori women smoke? And that really is historical. It goes back to the introduction of tobacco to New Zealand. Unlike North America, we didn't have a tobacco plant, so it was completely introduced, and it was introduced by the missionaries and the colonizers and the settlers, and they used it to trade and to buy land and etc. So it really was very useful for the colonists, given that it's a dependency forming when smoked. So the very big difference there is that Maori women took up smoking at the same time as Maori men, and we're talking in the late 1700s, early 1800s, whereas European women really didn't take up smoking until the 1920s and 30s. And so that's why there's such a big difference there between European and other females who their smoking prevalence is down to 12%. Now, in New Zealand, we have one of the highest rates of tax on tobacco relative to income. Australia has the highest if you look at just the amount, but relative to income, ours is higher. And because of our disproportionately higher smoking rates among Maori, and remembering the effects of colonization, Maori are overrepresented among the unemployed. All of those negative statistics apply. So among the lower socioeconomic groups, Maori are overrepresented. And then if you look at this, the amount of tobacco tax that is extracted from Maori per annum, this is just 2018. So in 1 year, on the left of that table, is the amount of tax that is from Maori men smoking and from Maori females smoking. The total tax, $306 million and $416 million per annum. We make up 15% of the New Zealand population. This is a huge amount of money for us. I was just going to also, I think I have a note on that slide if I can get to my notes. Now just to compare this, so in 1 year, the government is getting about $1 billion, $2 billion in tax. Over the last 31 years, there have been 90 deeds of settlement, so treaty settlements that the Crown has paid out on with different tribes around New Zealand. That total comes to $2.2 billion over 31 years. Just in 1 year, the government gets that amount from tobacco tax. So it's an extremely crushing amount of money that is coming from Maori there. And if you looked at, in this report, and it's on my website, just among young Maori women, 18-year-olds, and we also had the figure for, I think, 25-year-old Maori woman. It's a huge amount of money, and it contributes to keeping Maori immobilized, using Professor Green's theory of poverty, immobilized in poverty, dependent, and down, suppressed. Now, that's just one of the major policies used by tobacco control and disproportionately harming Maori financially. Another perverse effect that has happened with, and largely because of the tax increases, we had over in this graph on the right from 2015, we just had this enormous increase in aggravated robberies of corner stores, convenience stores that sell tobacco, aggravated robberies. The shop owners were being bashed, slashed with machetes. 2 men lost an eye, really, really serious. And unfortunately, the media reports which we analysed showed that most of the offenders were described as Maori or Pacific young men. And there was a report in the media as well that about 70 offenders had been imprisoned. Many, were caught. So there was obviously increased incarceration. And I'm sorry, I don't have the figure for you, but over half of the women in prison in New Zealand are Maori. So this is a major problem for us. And the last thing we need is another policy criminalising people for smoking. For example, we've just had bans on smoking in the car while children are present introduced. There'll be a $50 fine if you can't pay a fine, and there's just this flow-on effect that will disproportionately, I predict, affect Maori women because they have the highest smoking rates, and they're even higher among the childbearing years. So we are now moving towards criminalizing people who smoke, and it's when the Indigenous population have such disproportionately high smoking rates, we can only expect that these criminalizing policies will have a disproportionate effect on that population. The other thing that is happening is that we have smoke-free employment policies coming in. The New Zealand Defence Force went smoke-free this year. They are one of the largest employers in the country. And also, so there's just this increased exclusion, increased marginalisation and discrimination. District health boards, some have policies they don't want to employ people who smoke, and then also many landlords and also the government rental accommodation is the houses are smoke-free or the apartments are smoke-free. And there's talk to try and get the whole grounds, inside and out smoke-free. At universities, we have extensive smoke-free environments policies, and if they move to find more and more people breaching those, then that will continue to harm us. Now, I know I didn't have very much time, so I just picked out a few points there, and I hope I haven't rushed too much. My disclosures are that I've never been funded by a tobacco company or vaping companies. Many, many years ago, I did receive funds from a pharmaceutical company, and my support for tobacco harm reduction goes back a long way. I've been lobbying for oral nicotine products to be available, Swedish snus, for over 10 years. And I have a recent paper that would be of interest to you looking at the left behind subgroups, and that we looked at people with mental health, LGBTQ plus and Indigenous. And the interesting thing with that, it's, because often this disproportionately high smoking rates is put on the group, and everybody looks at the characteristics of the group. Oh, it must be something to do with being Indigenous and colonized. But, you can look at these three groups and the same pattern is there across all of them. So it suggests that there are external social and economic determinants of higher smoking rates. It's not necessarily the characteristics of the group. So thank you very much for having me to make this point, and I look forward to our discussion.
Hi, sorry, that took me a minute to get the buttons right. Marewa, that was an extremely interesting presentation, and I find it very disturbing that the rate of Indigenous women incarcerated in New Zealand is 50% Maori. It's 44% here in Canada, and it's so disturbing that that smoking is playing into this as well. It's terrifying. I'm looking forward to the questions that we'll have at the end on this. And now I would like to introduce Tracey Prentice and Trevor Stratton, who will be co-presenting back and forth with their presentation. So take it away, Tracey and Trevor.
Hey, Tracey, good morning. Good morning to everybody. My name's Trevor Stratton. I'll start out while Tracey gets her camera going. I'm in a different territory. I'm not on the beautiful territory of the Algonquin peoples. I'm in the Niagara region, which is shares a territory with Toronto. I'm actually a citizen of the Mississaugas of the Credit First Nation, and I'm on our territory. It's also the territory of the Haudenosaunee Confederacy, also known as the Six Nations of the Grand River, and the Anishinaabe. But I also need to acknowledge the Wendat Nation. This was their territory many, many years ago, and there's lots of Métis people and a very large Indigenous diaspora, probably the largest concentration of Indigenous peoples in Canada, are in Toronto. Yeah, so I've been living 30 years with HIV, and I have lots of experience with harm reduction. And that's me.
Thank you, Trevor. Sorry about the little glitch there at the beginning. My name is Tracey Prentice, and I am coming to you from the unceded Algonquin territory. I've been a grateful visitor here for almost 30 years. And really excited to present this work to you today. We're actually going to be talking about a couple of things. Primarily, we're going to be talking to you about Indigenous harm reduction equals reducing the harms of colonization. And so this is some policy development work that we did last year with two agencies, the Interagency Coalition on AIDS and Development and the Canadian Aboriginal AIDS Network. But when Trevor and I were talking about doing this presentation, we were also talking about the COVID, the context that we're all living in right now, which is the context of COVID-19. So we thought we'd be remiss if we didn't actually also share with you a few examples of Indigenous harm reduction in the context of COVID-19, because this work that you're looking at now was done prior to COVID. So we'll be sharing a couple examples of that as well. Whoops, sorry. So Trevor has done the land acknowledgement. We appreciate that. We also just wanted to acknowledge, the people that have contributed their time, their knowledge, and their wisdom with us to complete this project, and also the elders and the knowledge carriers who helped us do this work and to hold space for the focus groups that we conducted, but also all elders and knowledge carriers who, throughout the decades have kept their cultures, their traditions, and their languages alive. Sometimes at great risk to themselves, and without them, we wouldn't be here. So we just wanted to acknowledge that. Our partnership, we had an 8-person advisory committee for this project, most of whom were Indigenous. There's myself and 2 of my colleagues did this work. We are a consulting team called Stronger Circles. And I just wanted to draw your attention also to the design of the final resource. And so you'll see it throughout, but this work here was actually done by a young Indigenous man who was 15 years old at the time. He's a woodland Cree artist, and we reached out to him just because we loved his work, and also because we think it's important to support Indigenous artists and Indigenous owned companies, and then of course the funders. So the result of the Indigenous harm reduction work that we did was 1 policy brief and 4 case studies, and I'll share the links to that information with you near the end of the presentation. But basically, we had three basic principles when we were doing this work. We wanted our work to be grounded in community, and so we wanted the policy pieces, the policy development pieces, to be driven by the interests of community. We also wanted it to be grounded in JIPA. So this is a very well-known principle in the world of HIV and AIDS, the greater involvement of people living with HIV. It has also come to be known as nothing about us without us. So it was really important for us that people with living experience were not only feeding into this work, but were also helping us conduct this work. The third principle that was important for us was that it be decolonizing and indigenizing in our approach throughout. And so for us, that meant that there was an explicit recognition of the colonial legacy of research. And in practical terms, that meant asking questions about colonization and the impact of colonization on harm reduction and on indigenous communities. And it also meant listening for those references. It meant that there's always an intent to transform the relationship, to overcome issues of power, trust, and ownership. And for us, that meant, again, drawing on community-based participatory research approaches. It meant engaging elders and knowledge carriers directly in our work and grounding our focus groups and our sharing circles in Indigenous ceremony. So just in terms of what did we actually do, we did a literature review. We had 4 in-person sharing circles in 4 cities across Canada, all of which were co-facilitated by a local Indigenous knowledge carrier. We did additional telephone interviews with knowledge carriers, 3 domestically and 1 internationally, an online survey, and then Trevor helped us at the 2018 International AIDS Society Conference. Trevor helped us do some work around Indigenous harm reduction and solicit a broader engagement of experiences of Indigenous harm reduction globally. And so, did we actually achieve what we set out to do? We think we did. Overall, 41 peers were engaged in our information gathering process. 22% of those were elders. More than 50% were people living or with living experience. And we went through 3 rounds of review with our Indigenous advisory committee, and then 2 rounds of review of the final documents with groups of peers. And so that's a little bit about how we did the work. We can come back to this in the question period if there's any interest, but I'd like to pass it over to Trevor now to talk about our findings.
Thanks, Tracey. Harm reduction has always been very dear to my heart since I first learned about it. At first, I was confused about helping people to do drugs, but I realized that it's about helping people to reduce the harm without judging what they're doing, and that approach may have saved my life. I know I've heard many other Indigenous people with experience in drug use say exactly that harm reduction saved their lives. And I want to acknowledge Marewa around the tobacco cessation work that you're doing. It's incredible, and it's a great example of how maybe Indigenous harm reduction is a little different than mainstream harm reduction. In Canada, and across Turtle Island is what we call North America, a lot of us, tobacco is actually a sacred medicine with very powerful spiritual medicine. So if you say, if you take an abstinence approach with Indigenous people and say tobacco is bad, that is so easy for us to reject since it's one of our sacred medicines. But if you take an approach like non-traditional use of tobacco can harm you, then it opens up the opportunity for a discussion. So I really love that you opened up with tobacco, and I've smoked on and off throughout my life, and I'm not smoking right now, so I really appreciate the support, Marewa. Indigenous harm reduction acknowledges the importance of mainstream harm reduction, of course, life-saving and critical, but while mainstream harm reduction is life-saving and it's needed, we need it, in terms of Indigenous harm reduction, it's too narrowly focused on technological and behavioral interventions and not enough on the broader social system. Oh geez, I'm sorry. Somebody, my computer wanted to update one of its programs. It's too narrowly focused on technological and behavioral interventions and not on the broader social and system-wide issues that contribute to substance use for Indigenous peoples in the first place. I mean, let's face it, the health system, the legal system, the education system, social systems here, they weren't developed with Indigenous peoples in mind. They were developed by the people that came here and created them based on European ideals and worldview. Indigenous people are obscenely overrepresented in prison, for example. I have experience in jail myself with drug use, with sex work, and as I said, it was harm reduction that without that, I probably wouldn't be doing the work that I'm doing, and I feel very productive, and yet I still take part in drugs, alcohol sometimes. So, but people don't judge me, and I don't carry that weight anymore that I used to have, this shame and guilt. I'm just, I do what I do and I am who I am. Mainstream harm reduction doesn't address the need to disrupt the colonial systems and structures that put some people at greater risk of increased substance use in the first place. I needed to repeat that. Mainstream harm reduction has a range of policies, programs, and practices, and they're proven to reduce harms that are associated with substance use. Safe consumption sites, needle exchanges, opioid substitution programs, wet shelters, education, outreach, and naloxone distribution. These are, some of the central core activities in harm reduction. And it can also be applied to sexual activity with condom distribution, safer sex education, and outreach. And it's all life-saving. But mainstream harm reduction is criticized for too narrowly focusing on behavioral and technological interventions and doesn't necessarily address the broader social and system-wide issues that contribute to and intersect with substance use for Indigenous peoples in the first place. Mainstream harm reduction is about individual choices and not about systemic change. It doesn't interrogate those bigger pictures. If we don't deal with the larger issues, all the needle exchanges in the world aren't going to change anything. People will continue to reach for the medicines to feel better. And that's from Leslie Spillett, one of the knowledge carriers that was involved in the project. But Indigenous harm reduction, for Indigenous communities, harm reduction is reducing the harms of colonization, just like the title says. And if you Google that, you'll find the resource. If you don't have time to write down the link, just Google Indigenous harm reduction is reducing the harms of colonization. You'll find the beautiful resource. The main message, it's the main message throughout the resource that we all have a role to play to reduce the harms of colonization. Although it's inclusive of using substances, it isn't tethered to that. Rather, it's a way of life. It's love. It's non-judgment. It's non-interference. It's deeply rooted in Indigenous knowledges and worldviews, combined with the best of what the Western world can offer us, and focused on mitigating the harms of colonization. Indigenous harm reduction policies, programs, and practices are decolonizing. And that is interrogating asking the questions about the neo-colonial systems and structures in place that really constrain the lives of Indigenous people by centering power and control where it's been removed. It's supporting policies, programs, and practices that are community-based and peer-led, trauma-informed, distinctions-based, and culturally safe, and are reflective to ensure that the colonial systems are not replicated so we don't repeat the same thing over and over. Now, indigenizing is supporting policies, practices, and programs that are grounded in local Indigenous knowledges, traditions, teachings, ceremonies, the land, and languages where it's appropriate. They're strength-based and Indigenous-led from conception to implementation. Non-Indigenous organizations, peoples and organizations, pardon me, have a role to play, and that is learning how to work alongside Indigenous peoples and walk with us on our pathway to health. It's interesting that when I get together with my peers, you know, other Indigenous people living with HIV or people who use drugs, it's a very spiritual experience, something that doesn't happen nearly the same way when I'm with my non-Indigenous peers. I'd say that it becomes ceremony, and we begin to share some of the traditional teachings we carry. We had a Zoom call last night with an elder and Indigenous people living with HIV, and the elder didn't bring us there. We all brought us there as a group, and it felt really good and to be with my peers again. I missed them under COVID. We don't get a chance to hang out as much, you know, and we missed each other. Indigenous harm reduction is a way of life embedded within traditional knowledge systems that see the spiritual world, the natural world, and humanity as interrelated. Humanity is not separate from all the rest of creation. We are part of it. We have a sacred role to play, just like all of our relatives, the trees, the plants, the fish. It's all included. A very distinguished traditional knowledge carrier that works with harm reduction says harm reduction is love. And that's really beautiful. And some of our elders, many of our elders now actually are really coming around where they're not requiring Indigenous people to be what is that, clean and sober, quote unquote, for 3 weeks before coming in to get some treatment or to talk about traditions, about spirituality. They understand that maybe that's when they need it the most, and that is a huge, tremendous help to Indigenous people. You can't assume that someone who is high isn't spiritual. That just is folly. Indigenous harm reduction is holistic, whichever way you want to spell it. It's inclusive of, but much broader than, mitigating the harmful consequences of substance use. It's creating conditions in which Indigenous peoples can be mentally, physically, emotionally, and spiritually well, and ensuring equitable access to all of the determinants of health. And that's kind of, during lockdown, you know, there's a lot of people who are talking about mental health and how addictions and overdoses are increasing during COVID. And within the Indigenous worldview around health is a balance between the mental, the physical, the emotional, and the spiritual. And if any one of those things is out of balance, then we think of that as ill health. Indigenous harm reduction is inclusive. Indigenizing harm reduction, it has to include efforts to break down barriers of all kinds, to restore two-spirit, non-binary, and gender diverse peoples, also known as LGBTQI, etc., the whole alphabet soup though there. In Canada, often they put 2S in front of LGBT, two-spirit LGBT, you know, and because we say we were here first, we've been doing this for 10,000 years. Yeah, it restores that our identity and our two-spirit traditions, you know, to the honorable place that they deserve. And Indigenous harm reduction is about, oh, I lost my place, didn't I? It's about, you know, so Indigenous people can feel welcome and respected, basically, and feel like they're home. And because a lot of these systems weren't designed for us. So if there's a place that feels culturally safe, we'll be naturally drawn there. Indigenous harm reduction is innovative and evidence-based. To reduce the harms of colonization, Indigenous harm reduction has to combine the best of Indigenous and mainstream approaches. And there needs to be a full recognition that evidence comes in many forms. And that the Indigenous ways of knowing are just as important as Western knowledge, and combining them too and balancing it out depending on what that individual wants and where they're at, that is Indigenous harm reduction. But there are challenges to harm reduction, to Indigenous harm reduction. We're not all on the same page. Indigenous people are extremely diverse. You know, there's this thinking that abstinence is the opposite of harm reduction, or that they are opposed to each other. And I guess there is tension between them, because not everybody agrees that harm reduction is a valid or viable approach to treating harmful substance use. So these conversations need to happen at community and leadership levels within Indigenous communities. All our communities are different, just like human beings. They're all at a different place, and you need to start where the community is at. Where are they at? Our communities might be, you know, 50 kilometers apart, and they're very, very different, especially in terms of their readiness to talk about or to implement harm reduction. Stigma is a huge barrier to harm reduction. It's the single largest barrier. There's a strong belief in abstinence can lead to prohibition of harm reduction services, like that abstinence is so strong, the belief in it, that harm reduction becomes a bad word, and maybe people might avoid accessing services due to fear of being stigmatized or discriminated against. There's lots of barriers to service, discrimination by non-Indigenous health and social service providers, the fear of Indigenous peoples, you know, and it's exacerbated by those who use substances. Urban centers may not be culturally relevant or appropriate. And there's a lack of adequate funding, of course. We always come to that. Recommendations for Indigenous harm reduction policy and practice. There's 6 recommendations for Indigenous harm reduction, and harm reduction practices need to be conceptualized, led, and implemented by Indigenous peoples and communities, as well as be inclusive of those with lived or living experiences. Peer leadership, engagement, and support is crucial to the success of Indigenous harm reduction. Those with lived experience or living experience are experts in their own health and harm reduction needs, and those of their peers. So, more recommendations. We need to treat the person, the whole person, and not just focused on behavioral or technical interventions. They have to be diverse and inclusive and recognize and support the unique needs of each individual, community, and nation. Policies and programs, more stuff here. Evidence comes in many forms, and therefore evaluations must honor and acknowledge Indigenous knowledges, and that Indigenous communities know what's best for Indigenous communities. Indigenous harm reduction must be provided with adequate and sustained funding that is mid to long-term in vision, it's holistic, and includes peer-led and culturally grounded initiatives. So maybe at this point, I'll turn it back to Tracey to talk about some of the case studies that were involved here.
Sure. Yeah. Thank you, Trevor. So there's the Indigenous harm reduction policy document, which is about a 15 or 20 page document, and there are a couple of examples of what we would consider good examples of Indigenous harm reduction in that document. But we heard from community that they wanted more than that. They didn't want like a single paragraph. They wanted a little bit more information. And so we went back to our community partners and listened for and asked them specifically, you know, in your community or in your networks, give us an example. You know, what do you think is a promising practice? It didn't necessarily have to be an initiative or a project that was completed. It could be one that was just designed really well. And so we chose 4 of these promising practices to highlight in their own case study. And you can find these again on the ICAD website, and that we will provide the link to. And that's really what they are. They are promising practices. Some of them are long-standing, some of them are just up and running, but we also wanted to give examples that came from sort of many many different perspectives. And so the 13 Moons Harm Reduction Initiative is an Indigenous youth urban initiative, and it's designed and led by Indigenous youth in Winnipeg, Manitoba. Culture Saves Lives is a really grassroots, again, urban initiative, largely for First Nations, but Métis Inuit people are welcome. And Culture Saves Lives, if you have not heard of it, is in my view is groundbreaking. And so when I say grassroots, I mean it was started by a couple of Indigenous people who saw the devastation in their community, and at the time they couldn't find any elders to do ceremony. So we're getting back to the barriers that Trevor was talking about. Sometimes there are barriers within Indigenous communities to doing this kind of work, and so they just took the initiative to do it themselves. And so they went out to street corners, they went out to parks, and they started doing drum circles and doing their own ceremonies. And culture, in this particular case, culture has saved lives. Mommy Sarvik Healing Center is here in Ottawa, and it's the only Inuit treatment center of its kind in Canada. And then Sturgeon Lake Traditional Health Program as well. This is a unique initiative across Canada. This is an excellent example of traditional knowledge carriers working alongside Western trained, sometimes Indigenous, sometimes not Indigenous, healthcare providers. And so they work together. This was a vision that was shared with them by one of their community elders about 15 years ago, and they have been working ever since to bring this vision to life. And again, you can read about that in the policy documents that we'll give you the links to. In terms of ongoing work, and so all of those resources are available at this link on the slide here, but we also felt that we weren't done yet. And so we have applied for and were successful in receiving a knowledge dissemination grant or a knowledge translation grant. And the purpose of that grant is really to provide culturally relevant and community friendly resources. So an implementation guide, a social media package. We're going to be developing a series of videos with Indigenous knowledge carriers. There will be a website, and we'll also be developing 2 webinars to go along with this work. And so we just wanted to take the last few minutes just to share some examples of Indigenous harm reduction in the context of COVID-19. So Trevor, did you want to talk about Two-Spirited People of the First Nations?
Yeah, that's one of the hats I wear is my volunteer work is I'm president on the board of Two Spirits and in Toronto. And it's started out as an AIDS service organization, but with Indigenous organizations, we're holistic. So we realize that harm reduction is a lot more than just needle exchange. But under COVID, it changed things. But a lot of people were resistant to come in, of course, and there's restrictions. So we started doing harm reduction. The harm reduction training in person became online. Everything had to be converted. So people were being trained in naloxone and other harm reduction techniques. There's Zoom trainings for providers, but also for people who use the harm reduction services. And we're getting a lot of people are joining because they get food card incentives. So they'll mail them a $15 food thing for a supermarket, for example, and that's harm reduction. They're setting up tents in parks and doing needle exchange there, and when doing harm reduction to also provide the sacred medicines, not just the other medicines, other drugs, but the sacred medicines too. And they go out and they visit homeless encampments. When there's even though it's cold in Canada, there's homeless encampments of people who use drugs just outside of just about every urban center, or on the edges, or even in the valleys and in the green spaces. And we go there as well. And we do home delivery with food hampers, with handwritten love letters to people and medicines. A couple of people were saying, I can't, I'm getting wild meat from my community, wild hunted meat, and I have nowhere to store it. So, they give them a used freezer, things like that. And all the time, the opioid crisis and the overdose crisis is worsening. We're getting more and more more deaths. So that's a real challenge. And also more and more of our traditional knowledge keepers and elders are learning how to use Zoom and how to support people spiritually online. And that's a huge challenge, but we're overcoming it. And I'm really proud of so many of our elders, Tracey.
Beautiful. I love that example of Indigenous harm reduction, because I think that, you know, we live in, all of us, we live in such a biomedical world that we forget that sometimes what people really need is a hug. Right? What they really need is a human touch. What they really need is a phone call from somebody who cares about them. And that in many cases, that can make the difference for people, right? We hear it over and over again in the work that we do, that kind of stuff, we say, oh, anybody can do that, but it saves lives. And so here in Ottawa, I just want to tell you quickly about another project that we have adapted to the COVID context. And so this is a project called Nikanigana, which is an Anishinaabe word for all my relations. And so you know, we could do a whole presentation on what all my relations actually means, but in this case, it was a project that we did to address HIV stigma, initially to address HIV stigma and to address culturally unsafe care. And that's both in health and social services. And what we did is we brought together people with lived and living experience, knowledge carriers, health and social service providers, students, particularly nursing students in the first case, and researchers. We brought them all together for 4 full day ceremonies on the land. Wow. To talk about what is this thing called culturally safe care? Why is it important? What are the barriers, and how do we do it? And what we found in that initial project was that just the act of bringing people together from all of those different areas and sitting down in ceremony, we had 5 elders who worked together in this project, and sitting down and learning from each other, being able to see and to hear each other as people, not just as a service provider, not just as, you know, my doctor or my caseworker, but as a person, and giving everybody a space to be vulnerable, including service providers, which is not an easy thing. You know, we're not trained to do that. Right? We're the ones that take care of people. We don't show our vulnerability. But what we found is that when we give people an opportunity to do that, that it creates bridges. And so we had a really successful first project, and then COVID happened. And we had already planned to do a larger project. And then COVID happened. And so we adapted it for virtual context. And many of the same things that Trevor was talking about, we took those ceremonies online, and we did 7 virtual ceremonies, so 1 a month, with all of those same people, but we expanded it to include about 25 different people, 20 representing about 15 either academic institutions or healthcare institutions. So many of the hospitals here in Ottawa were engaged, the community centers were engaged, et cetera, et cetera. And we provided those teachings. Our elders, we shared door teachings, basically. We shared ceremony, we shared smudging, and people are really excited about continuing that work. And really, I think one of the main findings for us is that COVID is hard for everybody. This is a situation that we don't have a roadmap for. And so the service providers really benefited from this project, from the COVID project, possibly even more than the previous one, because they don't have anywhere to go. The service providers are experiencing the trauma at the same time as they're trying to help other people deal with that trauma. And so lots of learnings, you know, adapting to the virtual context, but people are committed because everybody realizes that that we need to be doing this work, and we need to be finding new ways of doing this work. And so I'll leave it there, because I know I think we're just about out of time, and I think open it up to, I guess I'll pass it back to the Senator, I think.
Hi. Thank you for that incredible presentation. That was very informative and many good lessons have come out of that. I see how important it is at this time when we are all disconnected with COVID and what's happened and having to adapt to an online sources, that how important it is to get on the telephone and phone people and just to have a human touch. So thank you for that. And I think we've got a few questions here. So let's start here. This is for Marewa. Tobacco taxation and smoke-free places are internationally recognized as two of the most effective approaches for reducing smoking in the world. Are you suggesting that tobacco be made more affordable for Maori people? Please explain your perspective. I also note that the Foundation for a Smoke-Free World is 100% funded by Philip Morris International, and that receipt of funding from this foundation is controversial. How has your funding affected your work and or relationships with tobacco control organizations in New Zealand? Thank you.
Okay, that's a couple of big questions there. What is effective is relative. So if, I showed the prevalence statistics that showed very, very slow reduction in smoking prevalence among Maori over decades, over the last 45 years. So what would be more effective would be the question to ask. And would Indigenous solutions led by Indigenous people have been better, have been more effective? And I believe they could have been. So whilst certain strategies may work for some people, they may not work for everybody, and they may not work for different groups in the same way. And that's what I argue and my colleagues in the Left Behind Group's paper. So I would really recommend people read that. Tobacco control takes a utilitarian approach. So what works for the most, and those who are marginalized are left behind. I do believe for example, now we're faced with as I said, a wide range of greatly risk-reduced products, and vaping particularly has proved very popular with people who smoke around the world. They have it's a mass exodus from smoking tobacco, commercial tobacco, to vaping. And I've never seen anything like it at all. The heated tobacco products as well have proven very popular in some countries. If I've always focused on how can we reduce the harm and the deaths, and in the most rapid way possible. And I can't. This switching to risk-reduced products it's much faster. I don't really want to distract from this very important discussion by talking about funding. What I can say is that as soon as I began to question the mainstream, as long as I was falling in line, and as we said in New Zealand, singing from the same song sheet, then you're included. As soon as I started questioning, actually the tax is hurting Maori particularly, and lower socioeconomic, as soon as I started questioning, then I wasn't as welcome, and I began to be pushed out. And that was a long time before I sought foundation funding. As Trevor mentioned, funding for Indigenous interventions is always precarious. There was a little time there where there was a group in Canada that was funded for tobacco control, a centre, and I also had a centre that was funded, and there was one in Australia as well. And we all seemed to run for about 11 years, and then we all got cut off. And So it's been very, very difficult, especially in tobacco control over the last 30 years. You know, I've met other Indigenous people from other countries there, from Canada there, and First Nations people, but nobody gets the funding on an ongoing basis to keep doing the work. And so there just isn't that continuity. So unfortunately for Indigenous people, the funding continues to be a problem. I'm very grateful for the foundation's funding. I have nothing to do with Philip Morris. I know that they fund the foundation, but I did my risk analysis and believe the foundation is independent, and we have a job to do, and I'm focused on that.
Great. Thank you very much, Marewa. That was a fulsome response. So the next question is for Tracey and Trevor. How does Western and Indigenous approaches to harm reduction blend? And do you have good examples of when they worked well together?
I can start, Tracey, if you like.
Sure.
I can actually think of several examples. You know, there's Indigenous people will come in, and you know, an Indigenous service provider will be on a street where there's lots of gang activity, and there's and drugs happening, and transactional sex, and people walk in and to get some clean equipment because they don't want to die, and they come in and they're handed some tobacco, a tobacco tie, which is sacred. You know, you burn it and you pray with it. And just that recognition of your culture and of your belief system and worldview, suddenly you come out of this foreign system and you come into a welcoming, culturally safe place where they care about whether you live or die, and they you know, come up to you in a culturally appropriate way with the protocols, with full respect, not from a power base of reaching down. And that can be, you know, the needle exchange part, I guess, would be the Western thing. And then, you know, the one place I'm thinking of in Regina, Saskatchewan, which is All Nations Hope Network. They have a round room that costs a lot of money to build a round room. And you try to convince Western architects and they say, there's so much wasted space. What if we just round the corners a little bit, you know? And then there would be an elder in there who may be from your own culture or from a nearby community, someone that understands the world views of Indigenous people, who can bring you into a spiritual place. Maybe that's their only access to that spiritual health, or the spiritual helper. There's such, and then it also can overlap into the mental health piece, and the elder can help a person understand that there's no reason for accessing mental health to be stigmatized, that there's no shame in it. It's just like you go to a doctor, an MD, you know, a medical practitioner for something wrong with your arm or your heart or your liver. That's a physical helper. There are mental helpers that can help you get healthy. And just to explain that through a cultural lens to an Indigenous person who may have been chewed up by a system that is very jagged and to us, you know, it's very, there's so many places where we can get hurt, where we feel disrespected or sometimes abused. There's plenty of examples, it's especially lately in Canada, about Indigenous people accessing healthcare and being emotionally and spiritually abused while they're dying, or being ignored in an emergency room for, you know, a day and a half because they assume that you're drunk when you're actually in diabetic shock. These examples continue to happen to this day. Colonization is very real to Indigenous peoples, and to have these spaces that have one foot in both worlds is extremely important, because most of us live that way, especially in the urban centers. we are navigating two different worlds and two different world views. So when we come into the safe space, it can be really nice. It can save your life. I'm gonna end there, Tracey, because I think that's the basic line.
Absolutely, yeah, and I'll actually just give you two examples from the Indigenous harm reduction work that you can look up online. And so we talked about the promising practices, and two of them I think are really good examples that respond to this question of how do you blend Indigenous and Western approaches. And so there's the Sturgeon Lake example that I've already spoke briefly to. And maybe just a little bit more about that. And so in Sturgeon Lake, when you have an issue, when you have something that you need help with, you can come to the health center and choose. So you can come to the health center and choose whether you want to talk to a Western doctor or do you want to talk to an Indigenous elder. And you can choose, you can speak with whoever you want. You can take as much time as you want to explore both of those avenues. And you can choose a healing path. You can choose to go a 100% Western route. You can choose to go 100% Indigenous route, or you can choose some combination thereof. And so they have spent an awful lot of effort and a lot of time learning how to blend these two approaches and learning how to work together. Because that kind of integration is not seamless, right? There are going to be stumbling blocks. There are going to be points where the perspectives diverge, if not clash completely. And so that's one example I would direct you to, and the other would be the Mami Sarvik. And so this is an example of an Indigenous healing center. It used to be called a treatment center. Now they call it a healing center. Sorry, I said Indigenous, I meant Inuit. And so it's the only Inuit healing center in all of Canada. And it incorporates, it is grounded in Inuit knowledge. And so they have Inuit elders, they have Inuit language speakers, they bring in country food, the staff is all Inuit. But they also offer what we would think of as a sort of a typically Western treatment model. And so I think those are two really great examples. And just one very briefly here locally in Sandy Hill, in Ottawa, there's the Sandy Hill Community Center. And so this is a non-Indigenous organization. But we worked with Sandy Hill in the Nikanigana project that I spoke briefly about. And as a result of that work, they have hired elders to be on their staff and to be available to people when they need them. They have planted a community medicine garden. They have bi-monthly Indigenous feasts where all Indigenous clients are welcome. And so they have done a number of things to not just to appeal, that's too surface, really to acknowledge that Indigenous people have different needs, right? And they have worked very hard to accommodate their space, which is a typically Western space, to those needs. And so I think those are three examples, but when you start looking, there are actually quite a lot out there. So I'll leave it there.
Wonderful, thank you very much, Tracey. The next question is for Trevor. Trevor, Indigenous people all over the world getting importance, but still in Pakistan are social isolated. No human rights, even no right of vote, less access to health care, facilities, etc. Is there any model for LMICs can empower the Indigenous people?
So we're talking about Indigenous people living in lower and middle income countries. Interesting. Unfortunately, it's all too common that Indigenous people are in many countries are not recognized by the governments, and they don't recognize the United Nations Declaration on the Rights of Indigenous Peoples. So that's the first challenge. But there is a place where Indigenous peoples collect globally, and it's at the United Nations at the Permanent Forum on Indigenous Issues. And we try to go every year to get Indigenous people talking about HIV and talking about sex and drug use, and that's not always easy, especially in a global context. So I'd say that's a good place to go. And I have seen Indigenous people from Pakistan and from that region of the world engaging at the United Nations Permanent Forum on Indigenous Issues. This year, it's going to be virtual. Last year, it was actually canceled, which set us back because we were going to have a meeting with some of the UN agencies, UNFPA, UNAIDS, PAHO, which is the Pan American Health Organization, that's the Americas division of the World Health Organization. And we were going to talk about, how do we start collecting data on Indigenous peoples? Just about any subject you look at, globally, it's really very hard to collect information. If you do a literature review to try to find a starting point, it's there, but it's quite difficult. And of course, some of it is in indigenous languages, which aren't recognized by the government. And when you do use the traditional search engines to do your research, they often don't pop up. So it's a big challenge. But I would say a starting point would be the United Nations Permanent Forum on Indigenous Issues. The problem for Indigenous people, I think, is that the United Nations, it's not the United Civil Society, it's not United Indigenous Communities, it's nation states. The same nation states that often think of Indigenous people as a threat, because we are sitting on what non-Indigenous people see as natural resources. We see it as Mother Earth, where our umbilical cords are buried, the connection we have to our mother. And those two worldviews often clash, and a place where these discussions happen on the global level is the Permanent Forum. I would suggest that maybe you can find out who are the groups in your country or region that are attending the Permanent Forum, and liaise, and sometimes they'll bring you along to New York City, or you get online and pay your registration fee or whatever. Thanks.
Thank you very much, Trevor. The next one is for Tracey and Trevor, and I know you touched on it in your presentation. I'm wondering how you're addressing device and internet access for your clients as a number of services have moved online.
You want to start, Trevor?
You go ahead. My voice is tired. No, I'm just kidding. Go ahead.
Okay. Because I think you had a really good example from Two Spirits, but I'll start. And so this clearly, in the age of COVID, this is a real challenge for individuals and for organizations. But what we've learned is that if you are adaptable, if you stay open to possibilities and you talk to people about what they need, is that you can find solutions. And so we have been able to work with our funders, and we've also been able to work with our community partners to transfer some funds. So often projects, whether it's a research project or a program or an evaluation or you name it, they have a budget line for travel. Well, in COVID, nobody's traveling anywhere. So what do you do with those dollars, right? And so we have found that when you talk to people, that they are quite open to shifting those dollars. And so we've been able to use some of that to support, to buy devices for individuals in some cases. But even if that option is not available to you, we have found that when we talk to our community partners and we talk to people with living experience, it's often possible to create spaces, to create opportunities. And so sometimes you meet in a park and you share a device. Sometimes a community organization is able to open a small space in their on their property, like in a tented area, and we share internet, and we share tablets, or there are creative ways of addressing those challenges. And I think it's going to be each situation, each local community will find their own solutions based on their needs. But if you stay open to it and look for ways, they are available.
The local interventions are the ones that are the most interesting, like expanding your Wi-Fi so it reaches out into the alleyway and the parking lot of your service agency. That just think out of the box a little bit. They have an outbuilding and they put a repeater out there so that people can walk by and stand there and text and stuff. But the example that I want to share is the International AIDS Society, which hosts the International AIDS Conference every 2 years. Of course, this year it was in July, but it all went completely online, which is a new experience for them. But they recognized early on about accessibility issues. So because they weren't spending all that money on travel and accommodations and food, the people who were granted scholarships, they doubled the number of scholarships. But those that were awarded scholarships also received a questionnaire asking them, what kind of a device you use? What kind of bandwidth does it have? How strong of a data system do you have? And there was about 20 questions. And they actually bought devices. They expanded people's access to the internet. And I thought that was brilliant of them. And it was the civil society that told them to do that, you know, because they have an ear open and they consult, which is a central tenet of harm reduction, is to, if you're providing services, you better damn well ask them what they want. You know, nothing about us without us is the core value there.
Thank you, Trevor and Tracey. The next question is for Marewa. Noting the unintended consequences of tobacco control policies that you outlined, to what do you ascribe the appallingly slow but steady reductions of prevalence rates in Indigenous populations in New Zealand? What policy approaches do you feel should be pursued by Indigenous populations to bring the prevalence rates down?
Thank you for that question. And basically, tobacco control has been led by the Anglo-Euro-Western community, and they control the narrative. They've decided what to do. The Framework Convention on Tobacco Control, which is a World Health Organization, you know, the first global treaty to address a health issue, is completely based on a Western, Euro-Western psychology and approach. What we really needed in New Zealand was for nothing about us without us, Indigenous people to be involved in saying what would work to reduce smoking rates. Our interventions, our Indigenous solutions needed to be funded. We needed to be funded in the same way to trial Indigenous solutions. I mean, I've run several trials. I even won a national contract to roll out one of my trials. But then, you know, they put a European person in to manage it, and it just fell over. It's so there just doesn't seem to be any understanding of this nothing about us without us, or perhaps Indigenous led solutions would work better, or culturally based interventions. So really, colonization and the ongoing institutional control by the colonizers is why we've had such slow reductions. And then all of those effects of colonization, the loss of land, the suppression of our healing practices and knowledge, the you know, trying to get all of it back. We're doing fabulously with decolonization, with reclaiming and reestablishing knowledge and practices, but still the funding is not in Maori hands. It's always like, put your hand out, and if you disagree, well, then you won't get any. So it's a real struggle. What do we want to do? You know, there are so many interventions that I have developed, that I've trialed, that get better quit rates. We just don't. We have a saying here, you know, like, always a pilot program, never a plane. And you know, so things get funded just for a pilot, and they hardly ever get rolled out. So I think that I've answered that question. Until we have I mean, a lot more like what you're saying, Trevor, you know, the nothing about us without us approach, Indigenous led, this decolonizing work that you have been doing there. And of course, now I do want to talk about the Sami, that because they're a success story really, and not by any kind of planned way, but Sweden has always had Swedish style snus, which is a powdered tobacco, moist. It's in a small bag and they put it up under their lip. Now the Sami actually, from what I can gather, have higher rates of snus use because they live up in the Arctic. It just fits the climate better there. And so they actually have lower smoking rates, that they potentially lower smoking rates than the Swedish Europeans and the people who split the Sapmi lands up. So they're a success story. Swedish style snus has been around for decades, a couple of 100 years. There's plenty and plenty of evidence that you will have much lower cardiovascular, lung cancer, etc. Sweden is the proof, and yet it's banned in many, many countries. In New Zealand, if we could have had that, we would have been able to save so many lives a lot earlier. And even now, today, the government has reaffirmed, no, it is banned. So what we really need is access to these risk-reduced products. We need a harm reduction approach like what you have, you know, what's been used in the drug and alcohol field and HIV/AIDS, and we need that in tobacco control. Now, there are other ways and risk-reduced ways of using tobacco, as you said, and the Indigenous ways of using tobacco were varied and many. It wasn't always smoked, and it wasn't always used in a harmful way. That isn't completely not recognized by Tobacco Control internationally. So you're lucky you have that as a precedent and recognized there.
Thank you, Marewa. Next question is for Trevor and Tracey. What are some of the politics or recognition that would be useful to help and support Indigenous people, their cultures and their traditions in an urban, which is the more detrimental than rural context?
Well, I'd begin by, you know, make no mistake, usually when someone else tells the story of Indigenous people, and if they're not Indigenous, it's a dangerous story. And a colleague of mine often says that. She says, you know, it's a dangerous story, and it's about our deficits, those poor natives, you know. And when we tell our story, it's about our strength. It's about our ancestors, our teachings, and our successes. This is how we tell our story. And I think that the best way to help, I mean, in Canada, we have the Truth and Reconciliation Commission. And there are some bunch of really good recommendations in there that make a big difference. So a good example, and the one that's being taken up by a lot of people, is acknowledging the territory, just as we did here today. Before we started talking, the very first thing we did is acknowledge the traditional territory of the Algonquin people. But you know what means even more is when a non-Indigenous person will do that acknowledgement and then talk about what that means personally to them. Or what does that mean to my organization or my institution? What is the historical context of my family or this institution with Indigenous peoples? That goes a long way. That reaches the hearts of Indigenous people, especially those that are from that territory. And, you know, I know that now they're teaching new immigrants to Canada, new Canadians, about the history of Indigenous peoples, which they didn't used to know. And now I'm meeting new Canadians who have an understanding of Indigenous people, and they're asking educated questions. I think that's a really good place to start.
Thank you, Trevor. And if I know we only have a few minutes, so if I can just add one thing, I think maybe part of what this question was getting at is that, you know, is that many Indigenous people live in urban centers, and, you know, urban centers attract Indigenous people, First Nations, Métis, and Inuit from all across Turtle Island, coast to coast to coast to coast, right? And so what we often end up with, in terms of, you know, offering services or offering programs, is a Indigenous program, right? And so we end up having this sort of this pan-Indigenous service that purports, or, you know, tries to serve all Indigenous people, but we know that that leaves people out. And so Inuit people, for example, often say that when they walk into an Indigenous organization, they don't see themselves. You know, many of the harm reduction services, or the videos, for example, or the you know, the documents that are produced for Indigenous people, don't represent Inuit understandings, Inuit culture, Inuit ways of knowing, even Inuit, you know, current realities, right? And so when we talk about the politics of representation, and how do we address those politics of representation, I think that's maybe part of what this question is trying to get at, and particularly in urban contexts. And I think, you know, there is no one right way of addressing this question, but I think there's two things to consider for those of us who are, you know, helping to design these services, or, you know, or want to, you know, recognize that there's a need and want to do something about it. One is to know and to recognize that that Indigenous people are not the same. First Nations, Inuit, and Métis are not the same. They do not have the same backgrounds. They do not have the same geographies. They do not have the same languages. They do not have the same, you know, the same worldviews, right? And so there's no such thing as a pan-Indigenous program that will appeal to all people. So distinctions based to a certain extent, but also recognizing that all of these people come together in one place. And then the other thing I think that would help us sort of address those politics of representation is take your lead from Indigenous people. if you take to heart that concept of nothing about us without us, and Indigenous programming, Indigenous resources should be informed by, led by Indigenous people, they won't steer you wrong.